Hello, my name is Dr. Eric Brown. I am currently the chair of the Medical Advisory Board of the National Kidney Foundation, Delaware and Maryland chapter. I'm also a senior physician with Mid-Atlantic Nephrology Associates. The National Kidney Foundation, serving Maryland and Delaware, is pleased to introduce Beyond Dialysis, a program series which includes valuable information about peritoneal dialysis, home hemodialysis, kidney transplant, and many other resources. I would first like to introduce Dr. Jeffrey Posner. Dr. Posner has been a practicing nephrologist for over 35 years. He did his training in internal medicine and in nephrology at University of Maryland Medical Center here in Baltimore. He has then entered private practice and has cared for patients with kidney disease ever since. He has extensive experience in peritoneal dialysis and is currently the medical director at DaVita Kidney Home Center in Catonsville, as well as the DaVita White Square Peritoneal Dialysis Program. Additionally, he sees patients on in-center hemodialysis, as well as transplant patients in the office. He is the current chief of nephrology at GBMC. And he is one of my partners with Mid-Atlantic Nephrology Associates. Please help me welcome Dr. Posner.
Well, I appreciate having this opportunity to speak to the National Kidney Foundation of Maryland and speaking to people who would like to learn more about the opportunities of home dialysis. Now, before we talk about what patients may want, nephrologists often think about what may be best for patients, and they obviously think about, gee, what if it was me? What would I want to do? And surveys have shown that nephrologists, 91% would prefer some choice of home hemodialysis treatment, and basically it's split in half between home hemodialysis and home peritoneal dialysis. Also, most nephrologists believe that we should aim to try and get 25 to 30% of new patients starting dialysis on home peritoneal dialysis treatment. However, the reality is very disconnected from what our target is. The reality is only about 88% of patients start on in-center hemodialysis, and therefore that means only about 12% of patients start on home therapies. So right now, as I said, about 88% of patients start in-center hemodialysis, and about 12% of patients do home therapies. And of that group, roughly 10% of all these patients do home peritoneal dialysis, and 2% do home hemodialysis. So let's talk about what is peritoneal dialysis. This is a photograph of a home dialysis cycling machine set up in someone's bedroom, right next to the bed, sitting on a nightstand. And this is a picture of that machine. There are two ways to do home peritoneal dialysis. The older method is called CAPD, continuous ambulatory peritoneal dialysis. The later version is called CCPD, continuous cycler peritoneal dialysis. And if we look over here on, I guess, the left hand of the screen, my right hand, you can see a schematic of how CAPD, continuous ambulatory peritoneal dialysis, works. Is you just take a bag of fluid, hang it on a pole, open up a connection, let the fluid infuse into the abdomen. We then clamp that off, let it sit there for several hours, drop that bag to the floor, and then drain that fluid out. As compared to on the other side of the screen, we have an automated cycling machine, which will do those fluid exchanges for the patient, typically overnight while you're sleeping. How does peritoneal dialysis work? What is this all about? Basically, what we're doing is we're using the body's own natural membranes, what's called the peritoneal membrane, which lines the inside of the abdominal wall and the abdominal organs, such as the intestines, and use the body's own membrane as the artificial kidney. We place a small flexible tube into the abdomen. We then use that tube to fill the abdomen with a balanced salt and glucose solution that goes into the abdomen, bathes the tissues, and the tissues themselves are very thin and filmy and have a very fine combination of blood vessels going through this very thin membrane, and the toxins go from the blood into that fluid, and then when we drain the fluid out, it is removed from the body. And either it's done 4 times a day with the CAPD, or it's done rapidly overnight with the machine. And once again, we see that same diagram that I showed you before. Once again, this is showing it in greater detail. You can see where the fluid is in this bag. We run it into the abdomen, let it sit there and bathe the abdominal contents in that balanced fluid. We then drain that fluid out, and it takes the toxins out with it. Over here, you can see a diagram of roughly what's happening. This yellow membrane in the middle represents the peritoneal membrane. On this side, we have the blood inside the tiny little capillaries, and these are our various water molecules, or you can also view them as the toxins, and they cross this membrane and go into the fluid that we have just infused into the abdomen, and that will remove it. Now, the water and the toxins are moved both by what's called positive pressure. They're actually being pushed across the thin membrane by the pressure in the blood, and they're also pulled across because the fluid has a variable amount of dextrose that will create an osmotic gradient, if you were, that pulls the fluid across. And that's how we're able to cleanse the blood and remove excess fluids. Technically, how does it work? We, as I said, surgically have a catheter placed in the abdomen. This is typically an outpatient procedure. People would go home that night. Typically, we want to wait 2 to 4 weeks before we start using the catheter to allow the tunnel and the exit sites to completely heal, to avoid leakage through the hole where the catheter is placed. Now, there are some instances where we're able to use the catheter sooner in situations where the patient really can't wait that extra 2 to 4 weeks before we initiate the dialysis. Now, an extra bit of detail in this diagram is you can see that there's the complete catheter. The catheter ends here, and we typically connect to that a transfer set that is then used to connect to the dialysis system. And we're able to place a clamp here on the system to prevent fluid from leaking in or out. Here is a photograph of a typical peritoneal dialysis catheter placement, and it's in the abdomen. What's important to note in this photograph, the exit site is far away from the patient's belt line, so we can avoid irritation. And once again, you can see the catheter is coming out of the body and then connected to this transfer set that we change on a regular basis to make sure that there's no issues with function or with infection. Now, in that diagram, you saw there was a clamp across the line right here. In reality, in this device, there's actually a roller clamp right here that closes off the system and prevents leakage. Here are 2 more examples. Some people will leave their catheter uncovered. Some will have a dressing on it, and that depends from patient to patient. The other interesting thing in this photograph is you can see this patient has a belt that after they've finished their treatment, they just slide the tip of the catheter in here, and they're able to go about their day comfortably without the catheter flapping around or being pulled. Another way of placing a peritoneal dialysis catheter, particularly in patients whose abdomens are less stable for whatever reason, often based on size, but not always, we can actually put a catheter up into the, that comes out in the chest wall, and then the catheter is tunneled under the skin all the way down to the abdomen. This is where your typical exit site would be, but instead, the catheter continues down into the lower abdomen, but the exit site is up here. Now, question is everyone a candidate for peritoneal dialysis? And the answer is no. There are some issues that really do prevent safe use of the abdomen. The biggest one is patients who have had significant prior abdominal surgery. If someone has had big surgeries in the past, or sometimes even just small surgeries or exploratory surgeries where a big procedure isn't done, patients can develop scar tissue, which leads to loss of that peritoneal membrane. Even if their abdomen appears normal, other than their little scar, and they've never had any problems with blockages or other issues related to the scarring, it can be there, and that can be an issue. Often we will, if the patient feels very strongly, we may ask the surgeon to try and place the catheter or look with the laparoscope and see how severe the scarring may be and see if they can maybe break up some of the scars and allow for an adequate placement of the catheter. Certainly, if someone has had a prior history of abdominal cancers, we do not want to be starting to put fluid into the abdomen and have that fluid slosh around. Rarely, some patients have what's called a ventriculoperitoneal shunt. These are people who've had essentially water on the brain, called hydrocephalus, and to release that hydrocephalus, a tube is placed from the brain, and it actually runs down into the abdomen and drains that excess cerebral fluid right into the abdomen. And because there's even a small risk of infection with peritoneal dialysis, any possibility of infection going up to the brain really is not acceptable. So that is a very strong contraindication to doing peritoneal dialysis. However, what people do need to realize is body size is not a reason to avoid peritoneal dialysis, or that someone cannot successfully be on peritoneal dialysis. Once again, the fluid is being, the blood is being filtered through those small vessels, and the treatments take place at home. And once again, the manual or continuous ambulatory peritoneal dialysis looks like this on this side, and typical cycler peritoneal dialysis looks like this. The peritoneal dialysis is something which, like anything else, requires training. We're not going to just drop the boxes off at your house, boxes of fluid in a direction manual and say good luck. The treatment training can last between 2 to 4 weeks, depending upon an individual's medical status and their learning style. The treatments are performed daily. The hemodialysis is a much more efficient chemical process, and therefore is able to be performed only 3 times a week to adequately cleanse the blood. The peritoneal dialysis is less efficient, which is good and bad. It's bad because you need to spend more time at it. The good thing is the exchanges by being done every day means that a patient gets dialysis every day. They're able to have fluid removed every day. They're able to have their blood cleansed every day. And that actually allows for a less restricted diet and more freedom of life. The manual or CAPD dialysis, which is this gentleman here sitting on the sofa, is typically performed 3 to 5 exchanges per day. Most commonly is 4 times a day. And I like to say it's when we're supposed to brush our teeth. Once in the morning around breakfast, once around lunchtime, once around dinner time, and before you go to bed. That usually is more than adequate for most patients, and we're able to get good dialysis. The exchanges take between 30 and 45 minutes, depending upon setup time and whether you need to warm the fluid and how quickly or slowly your fluid may drain from the body. With the cycler dialysis, which is down here, and actually, if I can go back, this thing goes back, let's see, yeah, in this picture down here, you can see that the patient has their dialysis machine on a nightstand right next to their bed. Prior to going to bed, they set up the machine, they weigh themselves, they take their blood pressure, determine what the appropriate solutions are to use for that night, set up the machine, connect themselves to the machine, and go to bed. The machine will be monitoring fluid flow to make sure that the fluid is draining appropriately and that people don't have issues with incomplete draining and the abdomen filling up and being painful. It does have a little alarm bell or buzzer to tell you if you've rolled over while you're sleeping and kinked the line. So it will gently remind you to roll over. There are no pumps involved in putting the fluid into the body. So if there is any sort of obstruction or problem with fluid going in, the machine's not going to force it. The pump is really there only to move fluid around through the system, and once it has left your body, it will pump it out. But everything else is done by gravity. So here we have a slide reviewing the benefits and disadvantages of the CAPD and the cycler dialysis. And the reality is most of the advantages are virtually the same for both systems, and the disadvantages are the same for both systems. The biggest advantage for peritoneal dialysis using either technique is you avoid needle sticks, and you don't have to have a fistula created in your arm or have a catheter placed into your shoulder or some other part of your body to get to the vascular system. One would think, gee, I have a catheter in my tummy, I have a catheter in my vein, infection risk must be the same. And the answer is that's not true. The infection risk associated with hemodialysis catheters is much higher. And that's because the catheter is going directly into the bloodstream. The body's best defense against infection is skin, and we've just punched a hole in it. Now, with the peritoneal dialysis catheter, the catheter itself has 2 cuffs, which are buried, one just under the skin and one into a muscle outside of the abdomen, which helps prevent bacteria from getting in there. And the procedure, as long as it's done according to your training, there's a very low risk of infection. Another advantage of home dialysis is you're on your own schedule. As I said, with the CAPD, you typically do it 4 times a day. But, you know, if 12 o'clock's not going to work and 2 p.m. is better, well, then you'll do your exchange a little bit later, and it doesn't matter. With the cycler, most people do it at night from, you know, let's say from 10 o'clock till 6 in the morning. But maybe somebody is a night owl and they don't want to go on the machine until 1 o'clock in the morning and get up at 10, you know, start their day at 10 or 11 or whatever it is. That's completely under your control. The peritoneal dialysis, as I said earlier, is a much more gentle procedure than the hemodialysis, which is part of why we have to do it 7 days a week. But it avoids drops in blood pressure. There's typically less post-dialysis fatigue than is seen with a hemodialysis treatment because we're cleansing the blood slowly and more gently and not leading to rapid shifts in the toxins that are circulating. The rapid shifts sometimes can make you feel bad. By having control of when your dialysis is and doing it at home or particularly in the evening, it's less likely to interfere with the ability to continue working during the day. Another thing that has been observed for both types of dialysis is your native kidney function, basically the ability to continue to make urine after you start dialysis, is better preserved and lasts longer with the peritoneal dialysis than it does with hemodialysis. And we believe that's likely related to either fewer episodes of low blood pressure, which can occur with the hemodialysis, or maybe it's related to some chemicals or something that you may be exposed to as a result of the hemodialysis. We don't really know for sure, but we do know for sure that the kidney function is better preserved. Now, what are some of the disadvantages of doing home dialysis and home peritoneal dialysis? Well, as I said, you have to do it every day. You really can't take a day off unless your doctor says you have enough residual function that you don't need as much dialysis. And that would be discussed on a patient-by-patient basis with your doctor. You do need to make the time to do the procedure on a regular basis. You need to have storage space. We're talking about, for the CAPD, 4 2 or 3 liter bags of fluid. A liter is about a quart, so we're talking about bags holding about a half gallon of fluid, and you need to store several weeks worth at a time, so you need space. Those bags can also be heavy. The CAPD bags, let's say they're a 2 liter bag, 1 liter of fluid is 1 kilogram, which is 2.2 pounds. So we're talking about a 5-pound bag of water. With the with the cycler bags, they can be 12 pounds, and the patient needs to be able to lift 1 or 2 of them to set up the machine. So it does take a certain amount of body strength to be able to perform the procedure, just because you have to be able to lift and move the bags on a regular basis. The peritoneal dialysis can lead to some body weight gain. And the reason for that is the dialysis fluids contain dextrose, which is glucose, which is sugar. And while that sugar, we use that sugar to try and increase the amount of fluid that's removed. The more sugar that's in the fluid, the more water that will get removed from your body. But some of that sugar will go the other way into your body, and some patients do have some issues with weight gain, and also if they're diabetic may need to make adjustments to their insulin solution, insulin administration. Another possible issue is that with the peritoneal dialysis catheter, there are limitations on swimming in some activities. Now, the reason that we're concerned about swimming is, depending upon where you swim, there may be bacteria or other organisms in the water, which theoretically could infect the site where the catheter exits the body. Our basic answer is, if you go in the ocean, you should be fine. If you go into a private pool where you know who's doing the chlorination and that there are no children or other people who could be having accidents in the pool, that's okay. We're not really crazy about public pools. And we also worry about lakes and streams because they may have unusual bacteria or other unusual organisms that could lead to an infection. However, Other than that, taking a shower, taking a bath, those are not interfered with at all. Some people are uncomfortable with the idea of having a catheter coming out from their body, and it affects their body image. And certainly, if that is an issue for an individual, then that could be a reason not to do the home peritoneal dialysis. We do, however, believe that PD should be the first choice for home therapy, and for a number of reasons. As I said earlier, it is less likely to lead to loss of residual kidney function, and those patients who have better residual function typically have longer survival, especially in the first few years while on dialysis. Also, with peritoneal dialysis, it's much easier to control what the slide says, control volume. It's easier to get fluid off your body and to keep you from getting swollen and having high blood pressure. Hemodialysis, that's a bit more of a challenge. As I just mentioned, with home peritoneal dialysis, especially in the first 3 years, statistically patients have improved survival compared to those who are doing in-center hemodialysis. And we're not entirely sure why, but some possibilities include, again, the preservation of native kidney function and that benefit that it gives the patient. Also, statistically, in the first 3 years on in-center hemodialysis, patients are more likely to have these tunneled hemodialysis catheters, which are associated with infection and increased risk of death. In addition, peritoneal dialysis is relatively easy to learn. The training, as I said, can take 2 to 4 weeks. I've had some patients who have completed their training in a week. I've had some patients who have needed the full time. And it is really just a question of performing the procedure as you're trained, learning to take your blood pressure, learning to weigh yourself, learning to make certain connections, and then just following the rules when you get home. Now, eventually, some people may need to transition to other types of kidney replacement treatment. Hopefully, the best option is for someone to get a kidney transplant. We've had some patients who have done home peritoneal dialysis for whatever reason they've needed to transition off of peritoneal dialysis, but still enjoyed the benefits of being at home and wanted to continue that, and transitioned eventually from peritoneal dialysis to home hemodialysis. By doing peritoneal dialysis early on, that will preserve your veins and blood vessels for future hemodialysis accesses in the future if those are needed. So to wrap up, I just want to go through basic questions that you may have about how the dialysis works. Once again, here are some photographs showing people doing the different types of dialysis. Where is dialysis done? It is done in your home. Now, what does home mean? Home can mean your home. It could mean your family's home if you have a dedicated space and you're living with them. We have had some patients who have needed to be in rehabilitation and they have been able to get it performed there. So being on peritoneal dialysis doesn't have to end if there's some situation where you need to leave. The other thing I didn't mention is you can travel with peritoneal dialysis. Let's say you are living in Maryland and you want to go visit Hawaii, or you want to go on a cruise. What we do is we arrange for the dialysis fluids to be delivered to the cruise ship or be delivered to the hotel. You bring your cycler and some other supplies with you on the plane or to the ship, and then you perform your dialysis just as you would at home. So traveling is certainly very possible with dialysis, with peritoneal dialysis. It just takes a little bit of planning and scheduling to make sure that it's set up in advance. The next question on this sheet, who performs the dialysis? The answer is you. In the United States, there is no availability of provider performed peritoneal dialysis. Now, again, you can be defined different ways. If you're caring for a family member who lives in your home and the patient would benefit from home treatment, but either physically or mentally is not capable of performing the procedure, we have had family members who have been trained and performed the peritoneal dialysis for the patient with the kidney disease in the home. Is there training? Yes, as I said earlier, can take, it says 2 to 6 weeks. I've seen some patients learn it in 1 week. Do you need a partner? No. As long as you are physically and mentally able to perform the procedure, there really is no need for a partner. Unlike hemodialysis, home hemodialysis, where if something bad happens, it happens very quickly and you do need to have somebody around. With the peritoneal dialysis, it's a slow process. Even if the machine shuts down due to a power outage, all you need to do is clamp it off. So as long as you are otherwise capable of performing the procedure and understanding what needs to be done, you do not need a partner. How frequent? Typically daily. When people first start dialysis, they may not require treatment every day, but that will be determined by their nephrologist and will depend on their specific situation and how much kidney function they still have. How long does it take? For the CAPD, the 4 exchange a day, typically 30 to 45 minutes per exchange. With the cycler at night, it's typically 8 to 10 hours. When do you have to do it? Whenever it works for you. You can hook yourself up at 3 o'clock in the afternoon to the machine and come off at midnight. You can hook yourself up at midnight and come off at 8 or 9 in the morning. For the CAPD, as I said, it's flexible. It does not have to be exactly every 6 hours. So you do have the ability to personalize your schedule and do what you need to do. How often do you see a doctor? Typically, you see the physician once a month and you visit the clinic twice a month. One visit with the nurses to review your progress, go over problems, and obtain blood and fluid specimens for laboratory testing, which is typically also only once a month. Then a second visit with the doctor, the nurses, and the entire team, which includes social worker, dietitian, possibly an administrator if necessary, whatever you need to be safe and stable at home. So the downsides, what is the access? As I showed you photographs, you would need to have a catheter placed in the abdomen. It is a surgical procedure. It is most typically an outpatient procedure. You don't need to spend the night in the hospital. And it's very well tolerated. The downsides, you need space. The dialysis solution contains sugar, and you have to have an abdomen that is capable of having the exchanges work. And this is just another picture of the same thing. So I think I will end there, and hopefully this has answered many questions and given you an understanding of at least the basics of peritoneal dialysis. There are kidney disease education programs that can go into greater detail. And if this is something that you are seriously interested in, you should visit a peritoneal dialysis training center to actually see the products, hold them in your hand, see what's really involved, and make an educated decision about what the best form of dialysis would be for you. So I'm going to stop the share and bring myself back on. And once again, I hope everyone found this useful, and feel free to contact me or go through your primary nephrologist, who certainly should be knowledgeable about this as well. Thank you and stay care. Take care and stay well.
Greetings. My name is Ku Kamwa, and I am with Quality Insights Reno Network 4. Quality Insights provides information and assistance to people with kidney disease in Delaware and Pennsylvania as one of 18 federally funded end-stage renal disease networks. Did you know that if you need kidney dialysis, you do not necessarily need to go to a dialysis center? Other available options can increase comfort, convenience, and safety. Many dialysis providers offer home dialysis services, and they teach patients to perform the dialysis treatment in the comfort of their homes. Meanwhile, on-site assisted dialysis is sometimes available to patients in a care facility, such as a nursing skilled facility or nursing home. Under this approach, dialysis providers come to the facility or teach nursing staff to assist with the life-saving therapy for residents who needs it. Home dialysis is underused in the United States. By raising awareness about these options, we can improve the quality and experiences for patients with kidney disease. Offering information about home dialysis and kidney transplant are just two areas where Quality Insights Renal Network 4 can help. Pre-COVID pandemic, we launched a patient advocate program as an ongoing effort to support patient engagement in their healthcare. Our two leading patient advocates visited 66 facilities and spoke to over 1,000 patients. One of the Network 4 patient advocates is here to share his dialysis journey.
As Kula mentioned, my name is Timmy Nelson, and I'm a kidney transplant patient. The short story of my diagnosis and my progress has been, I was diagnosed in January 2013. Now, I was a patient that had no symptoms. I was in the hospital for another procedure, and as part of that process, they did a creatinine test on me. I quickly learned that creatinine is a measurement of your kidney function. Or in my case, I measured how well my kidneys are not functioning. Fast forward, I began peritoneal dialysis December of 2013. I was waitlisted at University of Pennsylvania Hospital, April of 2014, and transplanted on July of 2017. Now, hopefully we have an opportunity to meet at some point in time and talk in person, but I have to share with you right up front that I cannot, I should not, and I will not offer medical advice. I'm not qualified to do that, but I am an open book about my ESRD journey, and I'll begin telling you that story right now. After I recovered from the shock of receiving the ESRD diagnosis, my doctor and I began conversations. The conversations were about dialysis, the different modes of dialysis, and also transplant, because my doctor shared with me that the ultimate goal that he wanted me to look at was transplant. And he also shared with me that there's no cure for ESRD. However, with my personal commitment to do the things that I need to do, life can have quite a bit of normalcy. After that, we began addressing the different processes for home dialysis, and I chose peritoneal dialysis. But he also reminded me again that peritoneal dialysis is a step in the process, but the ultimate goal for me was to work toward transplant. Now, so keep in mind, three things my doctor talked to me. Day one was about the conversation about transplant, the conversation about home dialysis, specifically peritoneal dialysis, and just as important, he talked about the role of me being involved in the process every step of the way. The importance of me stressing that the things that I need to do and focusing on things that I need to do. Keep in mind, I wanted to control my dialysis for a couple of reasons. First of all, I had a job that required me to travel quite extensively. In fact, I was on a plane 3 days a week at least. And plus I had a personal life that was very active. So I wanted a dialysis process that I could control, but yet provide the service that I need to manage my kidney function. So I began to adapt peritoneal dialysis to my personal life and my work life. Doing that, I also discussed with my doctor, why is this the best method to me to use for dialysis? And he shared with me, and I researched afterwards also to verify, that if you talk to medical professionals, at least 90% of medical professionals say if they had to go on ESRD, if they had to go on dialysis, they would choose a home dialysis methodology for dialysis, and particularly they chose peritoneal dialysis. So as my doctor and I began discussing further, we talked about who needs to know about my dialysis situation. definitely work. I can still work, but work needs to know that I need maybe some accommodations every now and then to make sure that I do my dialysis as I should do. We talked about my immediate family. That's my support team. They need to know what's happening with me, how my dialysis is working. And we also talked about my other medical doctors, my primary care doctor, my dentist, my podiatrist, my dermatologist. Those folks that provide medical care all need to know that I'm on dialysis. And so when they prescribe something for me, make sure it's compatible with my dialysis prescription. Home dialysis was also a bridge for transplant for me, because the training that I need to put in place for peritoneal dialysis and that discipline for peritoneal dialysis was the same discipline I needed to get ready for and to receive and to maintain my transplant. So adherence to my peritoneal dialysis training, that helped prepare me to get waitlisted, because I had to make sure that the things that I did were supporting my peritoneal dialysis. That helped me prepare for transplant, because as I had to get ready for transplant, there were certain things I had to do personally to make sure I was prepared for transplant. And now post-transplant, for the remainder of my life, there are things that I need to do to make sure that I adhere to my prescriptions to maintain my kidney function. I need to hold myself accountable, basically, for the medical instructions. And the other thing that I will share with you, I need to stay as healthy as possible to make sure that my kidney function stays as strong as possible. Now, I was afforded the opportunity in 2018 and 2019 to work with patients in the Network 4 territory. Both of those years, in the states of Pennsylvania and Delaware, I met with each 500 patients each of those years. And we talked about dialysis home options. We talked about the need for patients to take advantage of these options because it's a good methodology for dialysis. We also included the caregivers in the conversation. And I also had the opportunity to talk to staff members. Why was this important? Because as a patient, me sharing with individuals, here's how the process really works. It was compatible with what the doctor said, but when it comes from a patient, it's a little bit different. So sharing with these patients made a difference, and it helped reduce some of the fears and misconceptions they had. In many cases, patients had the fear that they could not home dialyze. And I shared with them, not only did I home dialyze, I did it when I was traveling. Often patients were shocked, but pleased to hear from a patient. Many patients they were satisfied with in-center hemodialysis, but they also said, but I do want to hear your story because perhaps I should consider that. Families also were involved because families wanted to hear my story and understand how the process worked and what role they would play in that process. I'll give you one example. I was in Western Pennsylvania and there was a patient that came in. It was not her dialysis day, but she heard I was going to be there, had read the pamphlet that the Network 4 put together to announce my coming and share my story. She and I had a great conversation. We talked about her being on insulin dialysis for many years. She said she'd never really considered home dialysis. After our conversation, she decided to try peritoneal dialysis. She began becoming a peritoneal dialysis patient, did it very successfully. Another year later, she went on the wait list and she was transplanted. And as she and I have spoken since then, she shared with me the conversation that we had encouraged her to try something different. Now, I'll share something with you also, is that sometimes conversations with someone who's gone through the process might be that encouragement you need to consider something else. I offer myself as that person to do that. I offer myself to you, to your families, to your loved ones, to your caregivers. Keep in mind, if I can be helpful, please reach out to Network 4 and I'll be delighted to assist with your dialysis process. Thank you.
Although we have been limited in providing in-person peer support, our Network 4 patient advocates like Timmy are available for remote one-to-one mentoring and virtual lobby days. Furthermore, we can offer educational resources for all types of dialysis options. Our foremost goal is to provide patient-focused services to the more than 20,000 dialysis patients in Delaware and Pennsylvania, helping them navigate the system and take an active role in their healthcare. If you'd like additional information, feel free to contact me, Kukamoa, at kkhamoua@qualityinsights.org.
Our next speaker will focus on home hemodialysis. Dr. Kiko Greenberg is an assistant professor of medicine at the Georgetown University School of Medicine. She is also the Associate Program Director for the Nephrology Fellowship at MedStar Georgetown University Hospital. Dr. Greenberg received her medical degree from the University of Virginia School of Medicine and then completed her internal medicine as well as nephrology training at Johns Hopkins Hospital. Her interests include chronic kidney disease, end-stage kidney disease, home dialysis, and patient education. She was the medical director of home hemodialysis while at Johns Hopkins, and she continues to care for patients on home dialysis at Georgetown. She's also the co-editor of the Handbook of Home Hemodialysis, which was just recently published in 2021. Please help me welcome Dr. Greenberg.
Hi, I'm Keiko Greenberg, and I'm a nephrologist at MedStar Georgetown University Hospital. I want to thank the NKF of Maryland and Delaware for inviting me to give this presentation, and I want to thank you for taking a little bit of your time to learn about home hemodialysis. I have no disclosures. So the objective of this presentation is to provide a brief overview of home hemodialysis and hopefully address any questions that you may have had about home hemodialysis. What is home hemodialysis? Well, just as the name suggests, it is hemodialysis that's done in an individual's home. So approximately 12,000 to 13,000 patients in the United States do home hemodialysis, and they come from a variety of backgrounds. These are some photos that I've taken from publicly available websites. So the treatments are done in the home, and then every patient has a monthly clinic visit with their nephrologist. This may be done in person in the dialysis clinic, or the patient may be at home and connect to the nephrologist via a telemedicine platform. Some of you may be very familiar with this machine pictured here. This is a machine that we use for in-center hemodialysis. The machine on the right is one of the machines used for home hemodialysis. So the vast majority of patients in the United States who are on home hemodialysis use this machine. So in addition to the home hemodialysis machine, the other key component is the water purification system. So dialysis can't happen without dialysate. The dialysate is the fluid that we use to remove waste products from the blood. In order to make dialysate, we require very pure water. So every dialysis clinic has a large room dedicated to purifying water through a series of machines shown here. At home, we use this smaller machine. So it's a box that typically sits under the dialysis machine. So in order to purify water, the water purification system must be connected to a water supply. So typically the water supply is a bathroom or a laundry. So this photograph is from one of my former patients' homes after his machine was installed after he started home hemodialysis. So you can see that this is a sink under bathroom vanity. So a close-up shows, so the blue tube takes water from the supply, to the machine, and the black tube is for wastewater and for used dialysate to be disposed. So if you own your home, you have to be okay with a small modification to your bathroom, possibly. If you rent your home, you will need to get permission from your landlord to install the system. In some cases, a patient's water supply in their home may not be suitable for dialysis, and those patients can use pre-made dialysate that comes in bags. I have a picture of that later in my presentation. So the home hemodialysis treatments are all done by the patient and their care partner if they have one. So that involves everything from cannulating the access, right, placing the needles into the fistula or the graft, or connecting the dialysis catheter to the tubing, and running the machine throughout the treatment, administering medications, if any, such as iron or epogen, for example, and then drawing blood and putting into the appropriate tubes and shipping them to the lab for analysis, and managing all the supplies that come with home hemodialysis. What's a care partner? A care partner is someone who's present during treatments for support and to act in the event of a medical emergency. Typically, this is a spouse or family member of the patient, but it could be a friend, neighbor, or anyone really. So all of our patients are given an iPad, and patients enter their vitals, such as blood pressure and weight. They can handle alarms and that might pop up during the treatment. After the treatment is completed, all the data is uploaded through a portal. And so, the physician, the nurses, can monitor our patients' treatments and make sure that things are going okay. So who can do home hemodialysis? Well, pretty much anyone. It does require a patient to have a home, and there are a small number of medical conditions that may preclude someone from doing home hemodialysis, such as active substance use or severe neurologic conditions. Typically, we do recommend that patients have a care partner, especially patients who are new to dialysis, but this is not always necessary. So you may be thinking that, wow, doing dialysis at home, seems really difficult. I'm not sure I can do it. And those are totally normal thoughts. Despite my expertise in home dialysis and having, counseled many patients about it and having taken care of many patients on home hemodialysis, if I had to do home hemodialysis myself, I find it quite daunting as well. So it does take some time to learn to do home hemodialysis. Typically, it's 4 to 6 weeks. And for some patients, it's longer. It takes more than 6 weeks, and that's completely okay. We don't send our patients home to do treatments at home until they're 100% comfortable. And the first few treatments at home are supervised by a nurse to make sure everything goes okay and all the equipment is connected properly. Now, why would anyone do home hemodialysis? For some patients, they value autonomy, so they want to be in control. For others, it's flexibility. So because you're doing dialysis at home, you really can customize the schedule, to make it work for you. So it tends to be easier to fit dialysis into your life. Right? We're all busy with work, school, childcare, elder care. We all have lots of obligations. And so home hemodialysis typically is a little bit easier to manage. And travel is possible with dialysis. Anywhere where electricity is available, you can do home hemodialysis. And so this is a photograph of Mr. Peckham, who was an advocate of home hemodialysis and a home hemodialysis patient himself. And this is a picture of him doing home hemodialysis, in the outside. And so you can see that behind his right foot, you can see the machine, the dialysis machine, and that above the machine are hanging dialysate bags. So these bags contain the fluid that we need to remove the waste products from the blood. And for others, patients would prefer to dialyze, in the comfort of their home than going to a center. And so you can dialyze, with family and friends present if someone desires. With home hemodialysis, it may be easier to keep fluid at bay. You're not limited to 3 treatments a week like in-center hemodialysis. And so some patients on dialysis have trouble limiting their fluid intake and tend to develop swelling or trouble breathing, especially over the long weekend. So at home, you can do more than 3 treatments a week, which allows you to remove more fluid total during the week if needed, or to remove a little bit less fluid each time. So the most common complication of dialysis is a drop in blood pressure. So for patients with low blood pressure, for example, patients with heart failure or liver disease, they start with low blood pressure to begin with. So they may have a hard time tolerating in-center hemodialysis. Well, if those folks do dialysis at home, we can customize their prescription so that each treatment is a little bit more gentle to try to avoid significant blood pressure drops. And there are potential health benefits of doing dialysis at home, such as improvement in blood pressure control, fewer medications, and possibly better quality of life. And of course, in the current climate, doing dialysis at home, allows our patients to avoid, exposure to COVID-19. So is home hemodialysis better than any other way of doing dialysis? Well, in general, there's no difference between home hemodialysis and in-center hemodialysis. However, there are some patients who may do better on home hemodialysis than in the center. So let's talk a little bit about prescribing home hemodialysis. As I've said, it can be customized to fit each individual. So in the center, patients are dialyzing 3 times a week during the day. And a small number of patients on home hemodialysis dialyze 3 times a week. But at home, doing dialysis at home allows you to dialyze at night if that's preferable. A lot of patients are dialyzing, every other day. They might dialyze every other day during the day or in the evenings. Other patients are dialyzing 4 times a week, either during the day or overnight. Some patients are dialyzing 5 times a week, again, during the day or at night. And others are dialyzing 6 times a week during the day or at night. So anyone who's dialyzing 5 or 6 times a week is called, they're doing frequent hemodialysis. Now, why would anybody do frequent hemodialysis, right? Most patients don't want to do more dialysis than is absolutely necessary. Well, so studies have shown that doing more frequent hemodialysis leads to an improvement in blood pressure compared to being on conventional 3 times a week dialysis in the center. With improvement in blood pressure comes, being able to use to take fewer blood pressure medications, and also regression of left ventricular hypertrophy. So the heart is a muscle. So individuals who've had high blood pressure for a long time tend to have left ventricular hypertrophy, shown here, where the heart muscle thickens. So patients on hemodialysis with left ventricular hypertrophy, if they start doing frequent hemodialysis, it's been shown that this heart muscle can actually shrink and return closer to normal thickness. Other benefits of frequent hemodialysis: phosphorus levels are better controlled. NP patients can take fewer phosphorus binders. And patients have more rapid recovery after dialysis. So instead of an 8-hour recovery time after dialysis, it might be anywhere from 1 to 4 hours. And possibly a longer lifespan. Although this is very hard to prove in studies. But given the other benefits, in improvement in left ventricular hypertrophy, better blood pressure control, it makes sense to me that frequent hemodialysis would be associated with a longer lifespan. So in summary, home hemodialysis has certain benefits over in-center hemodialysis. These include autonomy, flexibility, comfort, making it easier to keep fluid under better control, and potential health benefits depending on the individual. But the bottom line is that no dialysis modality is better than the others, and that folks should choose what works for them. And of course, keep in mind that you can always change modalities. So you may start on in-center hemodialysis, but you may choose to switch to home hemodialysis if that works for you. Thank you very much for your time.
Okay, so my name is Austin Lee. I'm from Clinton, Maryland. I'm a 2-time kidney transplant recipient from 2 living donors, and I have undergone peritoneal dialysis twice in my life. Once from the age of 1.5 years to about 4 years old, and then afterwards I received my first life-saving organ of a kidney transplant from my mother, in which that transplanted kidney functioned for 14 years. I was on dialysis from 2007 to 2010, and that is when I received my my second kidney transplant from a living donor, and it was by way of paired exchange. It's not easy when you receive it, because when I received my kidney transplant, I didn't go through the easiest transition. I mean, because the medications and everything. So even through that, you have to overcome. But understand, it's the freedom, because once you receive that kidney and it's working, like, you no longer have to be bound to any type of machine. Getting rid of waste and regulating your potassium, your phosphorus. Whereas, when you're on dialysis, you have to take medications to regulate those things. Like now, I don't take anything to for potassium or phosphorus, because that's what my kidney transplant does. So my kidney is the medicine. If you're on dialysis and you're kind of fearful of getting a transplant, write down what you think you could do with a transplant, and then think about what you can't do because you're on dialysis, and kind of weigh those out.
Dr. Silke Niederhaus is an assistant professor of surgery at the University of Maryland School of Medicine. She received her medical degree from University of Alabama and completed her surgical residency, as well as a 2-year research fellowship at the University of Wisconsin. Following residency, Dr. Niederhaus completed 2 years of subspecialty training in abdominal transplantation, also at the University of Wisconsin. Dr. Niederhaus specializes in kidney and pancreas transplantation, laparoscopic and single port donor nephrectomy, and dialysis access. Dr. Niederhaus has a number of papers and abstracts published, many centering on organ transplants, as well as organ donors and recipients. Dr. Niederhaus herself is a 2-time kidney transplant recipient, and therefore she brings a unique perspective to the field of transplantation and immunosuppression management.
Good morning, I'm Silke Niederhaus. I'm a transplant surgeon at the University of Maryland School of Medicine. I'm also a 2-time kidney transplant recipient. And for this year's Beyond Dialysis, I'll be giving a brief introduction to kidney transplant. So first off, to disclosures, I do serve on the board of directors of the National Kidney Foundation of Maryland and Delaware. And I did receive a speaker honorarium this past year for participating in an American Society of Nephrology event. For patients who have kidney failure, there are really several options for managing the kidney failure. So kidney failure in that case is defined as a GFR less than 20, or being on chronic dialysis, which could be either hemodialysis or peritoneal dialysis. Really, once the GFR reaches less than 20 is probably a wonderful time to start thinking about what to do next, because most people with a GFR of 20 do not yet require dialysis. And so it's a good time to think about what kind of dialysis someone might want to do, if they want to do dialysis at all, or if they're of significant age where maybe saying, I don't really want to do dialysis. And, if kidney failure is what takes me, that may be good enough. In that case, it may be worth consulting with someone in palliative care. For those who are healthy enough to survive without cancers or infections being a very high risk, transplantation is also an option. And usually we start the process of workup and listing when someone's GFR or glomerular filtration rate reaches less than 20. When people have kidney failure, there's often underlying causes. Most common in our country are diabetes and high blood pressure, followed by things like glomerular diseases or hereditary problems, congenital problems, or kidney cancer. Those are a lot less common, and diabetes and or high blood pressure really do make up the majority of people with kidney disease. So when we talk about the things we can do when we have kidney failure, hemodialysis is one option that comes up a lot. And many people have experience with this, because if you don't know that you have kidney disease and you show up with significant kidney failure in an emergency room, probably hemodialysis is the starting point then for many people. Hemodialysis can be done either at home or in a center. And it's done either through a fistula or a graft that's in the forearm or the upper arm or the thigh. Generally speaking, all types of catheters that are used for hemodialysis are somewhat bad or risky, because they have a risk of infection, and they also have a risk of causing narrowings or stenoses inside the blood vessels that they sit in. And those narrowings then make it very hard to put a fistula or graft at a later point in time. Fistulas or grafts usually last longer and have fewer infectious complications than catheters. Most outpatient hemodialysis is done 3 to 5 days a week, 2 to 4 hours at a time. There are some centers that will do dialysis overnight. And all hemodialysis can have complications. Common things are infections that happen either of the catheter, sometimes of a graft or a fistula, pseudoaneurysms that are at risk for rupture or need other revising, or then fistulas or grafts that don't mature or they clot. And by having narrowings or thromboses need further care. So dialysis is really a full-term commitment, and there's unfortunately not one operation that gets you set forever, but this is a relationship that you're gonna have with whoever manages your dialysis access. Peritoneal dialysis, similarly, can require multiple procedures. The beauty of peritoneal dialysis is that it can generally be done at home by the patient themselves or by a caregiver. For peritoneal dialysis, there's no catheter inside any blood vessels, but a different kind of catheter is implanted in the abdomen. So it goes through the abdominal wall, or we can tunnel it all the way under the skin out the chest. And through that catheter, there's then a two-way tubing through which fluid flows in, stays in there and dwells. And then when it's time, moves back out. And then this clears all the waste out of the body. These catheters, once they're implanted, can clog, they can kink, they can get engulfed by bowel or omentum and not work for that reason. And these catheters can also get infected either on the inside or on the outside, and that may require additional surgery to fix. Many people, I mentioned already, have diabetes as one of the causes for kidney failure. And so there is an additional option for those patients to consider pancreas transplant at the same time as a kidney transplant is considered. For those patients, these are usually people with diabetes on insulin. So the insulin is a key part of this diabetes. The BMI should be less than 32 or 35. So ideally not obese. Overweight may be okay. Minimal obesity, depending on the distribution of your body fat, may be acceptable as well. Ideally, the insulin use should be there, but not very high, so less than 100 units per kilogram per day, or be using an insulin pump. This can be done for patients with type 1 or type 2 diabetes, and in some cases also for patients who have pancreatitis after a total pancreatectomy. Pancreas transplants can be done either as a pancreas alone or a pancreas after kidney, or as a kidney and pancreas transplant simultaneously. So they're an often overlooked field of kidney transplantation, but I think since so many people have diabetes as a cause of kidney disease, this is something that should be considered for every single patient who has diabetes. So once you have kidney failure, we already said there are so many choices. First, you have to choose between dialysis, and many people will need dialysis while they wait for the kidney transplant. And then transplantation, either as a kidney alone or a kidney and pancreas if you have diabetes. And then additionally, the options for transplant are just as manyfold. So when people come for evaluation, there's often a lot of questions and confusion and just overwhelmed looks on people's faces, because what does all this mean? So in short, I can summarize that if you need a kidney transplant, getting a living donor kidney from a friend or a family member or a friend of a friend is the best. And the reason for that is that living donor kidneys are cherry-picked. We don't let living donors who have a little bit of a health problem donate many times because we want the donors themselves to live a long, safe, and happy life without kidney failure. Now, if anything were to happen to all these donors that we said no to, and they were to die, we probably would take their kidneys in a heartbeat, and they would probably be among the better kidneys that we have from deceased donors. So if you have any chance to find a living donor, by all means do so and allow them to be your donor. On average, a living donor kidney lasts about 15 years, and only 3 out of 100 times is there a problem with the kidney where it fails in the first year after transplant. So these kidneys are just awesome. Kidney transplants in general from deceased donors last on average about 9.5 years. So good 5 years less than the living donor kidney. And they may not function right away, making the recovery a little more tricky because after surgery, some people may still need dialysis. That's the kidney everyone will be listed for no matter what. And now there's about 4 other lists that people can choose to sign up for as well. And those will open up opportunities and give a chance to get transplanted sooner. It's important to remember that every year that people spend on dialysis is a chance of dying. And the risk of dying on dialysis is actually not insignificant. For people who are in their 60s and they start dialysis, there's probably a 50-50 chance of still being alive after 4 or 5 years. So it's a good thing to start thinking about how to get a kidney and how to get it soon. That's why the living donor is so great, right? Once you find someone willing to donate, you're ready to get off the list. So in order to shorten wait time and be on other lists, the first option that's often discussed is what's called a high KDPI kidney. And that's a bunch of medical gobbledygook for just meaning a heavily used car, right? So this is not a new car. This is not a 1-year-old car. This is the car that's been through the ringer. This is a kidney that's lived its life. It still works. If we don't think the kidney will work well at all, we usually throw them away. But unfortunately, there's no perfect test for us doctors to use to predict which kidneys will do great and in which patients they will do great in. So sometimes it's just a combination of the wrong kidney and the wrong person. And sometimes that is an unpredictable thing, and we do the best we can, but we're still just human. So those high KDPI kidneys basically are special because they're only designed to last about 5 years. And that's about a third as long as a living donor kidney and half as long as the other kidneys on the list. And so that's an important thing to consider. But for some people whose life expectancy is not that long, or who have a high chance of dying if they stay on dialysis for 5 or 10 years while they wait, this may be a way of avoiding death. And so even though it's not perfect, right, you have to remember an average is an average, and some of these kidneys may very well last 7, 8, 9, or 10 years. Other kidneys are kidneys that have risks of infection. So we look at kidneys from donors that have hepatitis B core antibody. And that basically means the person had a hepatitis B infection and got over it, but there's probably some hepatitis B in the cells that comes with it. If people have been vaccinated for hepatitis B, usually nothing else needs to be done, and your immune system just takes care of what needs to be taken care of. So I kind of call this a no-brainer kidney because the choice of living with it or having a problem with it is very easy in my mind. Some donors now have hepatitis C virus infection. That's a little more involved because if you get a kidney from a hepatitis C positive donor, and we encourage people to ask about that and say yes to it, it basically means that for 2 or 3 months after transplant, you need to be under treatment for hepatitis C to get that virus under control. And once that virus is controlled and not making copies of itself anymore, you shouldn't have any problems down the road with liver disease, liver failure, liver cancer, or death. But there is always the off chance, because in medicine, everything happens at least once or twice, even if it's not expected. So far, patients have done very well with these organs. Many of them are from younger donors. And the treatment is almost 100%, between 97 and 99%. And there's other treatment options if the first one fails. And then lastly, some of you that have been on the list for a while have probably heard of the PHS increased risk donors, and that keeps coming and going. Some donors, because of their health habits, have a higher risk of transmitting hepatitis B. We already said we're usually not too worried about that. Hepatitis C, which our screening tests are very good for, and we sometimes transplant that on purpose now. And lastly, HIV, which is still disease that requires lifelong monitoring and medications, so will make transplant a little more tricky. So those at this point in time, we don't consider having to have a separate consent for, because it's very rare that infections get transmitted accidentally with our screening tests, but we would still let you know if we think the risk is higher than average. So the advantages of the living donor transplant, like I mentioned earlier, are that it's a daytime scheduled surgery, right? You can do this in the summer on vacation if you want to do that. The kidney usually works immediately. People feel better almost immediately. The kidney works better. The kidney lasts longer, and the waiting time is much, much shorter. So if you're interested in learning how to find a living donor, I encourage you to attend the National Kidney Foundation's Big Ask, Big Give event. That's usually held once a year, either remotely or in person. We very much hope that it can be an in-person event, but with Omicron currently going around, I'm not sure it will or will not. We'll have to wait and see. We talked already after the living donor, the next best case is this average kidney from the list, and that lasts about 9 years. The most important thing you can do as a transplant patient is to make sure to take your medication very, very faithfully, to not run out of medication, to call ahead to get your refills, and to make sure you get your labs checked every month, because there's really no good way to tell if you have an early rejection other than your labs. And rejection is best treated if we find it early. High KDPI kidneys, I already mentioned. The KDPI stands for Kidney Donor Profile Index. Those kidneys frequently need some dialysis before they start working. They require sometimes what I call a little bit more maintenance, right? If your creatinine is not perfect to start with and you get a little urinary infection, you may need to come to the hospital for us to monitor your potassium a little more. And it's expected to last about 5 years. Hepatitis B, core antibody kidneys, like I said, most of these transmissions are prevented by the hepatitis B vaccine, which usually everyone gets when they start dialysis. Worst case scenario, if you do get an active infection, it generally means that you have to take 1 or 2 pills a day, in addition to your transplant medications for a lifetime. That's very, very rare. And for the most part, this really dramatically reduces waiting time. And I call it the no-brainer kidney, because would I rather spend another year on dialysis or have a 1 out of 1,000 or less chance of catching an infection that I need to take 1 more pill for? I take 10 pills a day already, so what's 1 more? To me, it doesn't matter. Hepatitis C, like I mentioned, is a bit of a new idea. Like I said, the treatment is very good, works 97 to 99 out of 100 times. There's a very rare chance of getting acute liver failure from hepatitis C infection. Indeed, I have not seen that yet. And I say yet because, like I mentioned, in medicine, you can do the same thing 10 times and have 10 different outcomes. So it just is a tricky field to work in for that reason. Generally, the insurance companies will cover the medication to treat hepatitis C. If for some reason your insurance company were to refuse, that could be a costly treatment. The alternative would be to just watch and monitor your liver closely, but we don't recommend that. Now, most recently, we've started actually transplanting organs from people who have a history of COVID-19 and then die for another reason after they've had this infection, or who die several weeks after the infection was really there from complications of COVID-19. So ideally, we want the infection to be past, meaning for us over 21 days ago. And we want to make sure that whatever organs we use, be it liver, kidney, or pancreas, are not affected, right? So probably using a lung would be a very risky thing to do. As of right now, nobody has proven that infection can be transmitted through liver or kidney transplantation or pancreas transplantation, but there have been some studies showing some evidence of viral infection in these organs at times. So I think we just need to take it slow and be careful and make sure that when we use organs that may have a COVID history, that these organs are screened appropriately, that patients are followed appropriately, and if the infection is a bit more recent than past, that we transplant these organs at a time when the right prophylactic and antibody therapy may be available to the recipients. So this is a changing field on a day-to-day basis, and probably what I'm recording and saying today may not be valid anymore in March or April or May, because all these things, like I said, the therapies change and what's available changes, and the virus keeps changing. So it keeps us on our toes. As far as the PHS increased risk guidelines, if you want to know more detail of what donors would qualify as PHS increased risk at this time, basically we ask the family of the person who passed if within 30 days before their organ donation, they had sex with a person who is known to have any of these infections, men having sex with other men, sex in exchange for money or drugs, sex with a person who had sex in exchange for money or drugs, drug injections for non-medical reasons, sex with a person who injected drugs for non-medical reasons, incarceration for a prolonged period of time, child nursed by a mother with HIV infection or born to a mother with any of these bloodborne infections, or if the history is unknown, they may also be considered to have an increased risk for catching one of these infections and us not detecting it on our screening. So the new kidney surgically goes in the pelvis. It doesn't go where the old kidneys were. The old kidneys stay in. We try not to touch them because they're surrounded by other organs like the gallbladder, the liver, the spleen, the adrenal glands, the pancreas. And if we can leave all that alone, we're generally better off. There are some exceptions for people with large polycystic kidneys that get in our way, or people who have cancers in their kidneys. But for the most part, we leave the old kidneys alone. The surgery, therefore, is easier. Our cut can be made sort of like a diagonal thing in the corner of the abdomen, mostly on the right side, sometimes on the left. The ribs don't get in the way of our retractors that way. There's very few other organs other than just your bowels around, and those get moved and pushed out of the way easy. And the other thing is the ureter you see here, the tube that connects the kidney to the bladder, can be very short. And that's important in order for that ureter to have good blood flow, because here the ureter gets blood from the renal artery going into the kidney, but it gets blood flow from the aorta through other little side branches, from the iliac artery, and from the blood vessels that feed the bladder. Those blood vessels are all cut when we take the kidney out, and so the only blood flow left is the one from the kidney itself. So the shorter the ureter, the better. So it's happy in the front here. It's also an easy place for the nephrologist after transplant to get a biopsy sample. So what to expect after kidney transplant? Usually it's about 2 to 5 days stay in the hospital. When you wake up, there will be a tube in to drain the bladder. You can expect your kidney to work right away or maybe not work right away, and your doctor probably will give you an estimate of the chance of that. When you're in the hospital, you're going to be basically in school. There's going to be about 20 new medications that you're going to have to learn and know and learn to take. The first day or two, you're going to feel pretty sore. Most places will let you eat as soon as you're hungry. And in the beginning, I tell everyone you need to count on coming back to your transplant center at least once or twice a week. So it's a lot of trips to Baltimore. For those of you who live away, you may want to choose to stay with friends or family or in a hotel for a little while and plan for that. Complications, it's surgery, right? So anything that can go wrong will go wrong. There are things that are common and things that are rare. Usually the things that are rare are pretty disastrous and things that we don't want to happen. So blood clots in the artery or in the vein that can cause the kidney to be lost immediately and not work. Some diseases can come back right away and injure the kidney. The bowels could get injured. That's, again, pretty rare, but very messy when it happens with infection. Very rarely do people develop a cancer after their transplant called PTLD. But again, if that happens, that's a lot of additional therapy. And then there could be an injury to the blood vessels, which could then compromise how well your leg works or how good of blood flow your leg has. Those are, like I said, very rare. If they happen, they're a huge deal. And there's lots of investigating and us thinking about why did this happen? How can we make it never happen again? And the truth is, a lot of times they're spontaneous, sporadic things that just do happen because it's medicine and not math. And we can try to prevent it again, and it'll happen yet again. Common things are some numbness on the thigh, either on the side or the front of the thigh, a little fluid pocket either under the skin or near the kidney that may need to be drained either through radiology or with another small operation. The urine, where the ureter is connected to the bladder, can either leak or stricture. Imagine it like plumbing, right? The toilet can leak or it can clog. Many men can get some swelling in their scrotum, women in their labia, that can usually improve with time. And then there's things like rejection that about 1 out of 10 people get. Hernias, where the wound just doesn't quite heal right. And many people long-term after transplant do get skin cancers. So it's important to be in touch with a dermatologist and to wear a lot of sunscreen. So at our house, my nickname is Queen Sunscreen every summer and winter. In general, for COVID-19, I thought about revising this slide, but I think this is still the absolute key. If you have the ability to get vaccinated, you haven't done it yet, you're not sure about the vaccines, talk to your doctors, talk to your nurses. If you're thinking about getting a kidney transplant, a liver transplant, a heart transplant, a lung, a pancreas transplant whatsoever, these vaccines work so much better before the transplant than they do after. And you'll be better protected if you start getting vaccinated for any disease that you haven't been vaccinated yet before your transplant. So that's true for COVID, but it's true for shingles, it's true for measles, mumps, and rubella. If you're a person that just has never been vaccinated, I encourage you to think about it, because really, truly, we do know that the protection is best if the vaccines are given before people start immunosuppression. When you get transplanted, and you may still get transplanted during a pandemic, it'll be double and triple important to be smart about that. Wear a mask wherever you go. There's different levels of masks. Cloth masks are the least protective. N95 masks or full-on respirators are the most protective. And then there's these KN95 masks and surgical masks that are somewhere in between. Keep your distance from people, especially people who are sick, and that's true even if it's just flu season. Wash your hands a lot, because you don't want to get any germs that way. And just be germ smart in general, right? Wash your hands and do safe things. And, if someone around your house has a gastrointestinal illness, make sure you wipe down the doorknobs and the light switches and the flushing buttons on the toilets and the handles for the sinks, and wipe them down a lot to keep them really clean and keep others from getting sick.
Next up, we welcome Christiana Care Kidney Transplant Center with special guests sharing their transplant journey. You will meet Sharon Francaccini, Outreach Coordinator for the Transplant Program, as she introduces to us Matt and Christine Hall and Matt's kidney donor Jackie to share with you the benefits of living kidney donation.
So Matt, tell us about your story. How did you get to the point of needing a kidney?
I was diagnosed in 2000 when I was 16 through a physical for high school sports. At that point, I had a kidney biopsy, and it was determined that I had FSGS, which is focal segmental glomerulosclerosis. At the time, they said it would be probably roughly 20 years before I would need a kidney transplant. And true to form, when I was 36, that's when I was told that I would need a transplant or go on dialysis.
What was your life with kidney disease? How did you feel?
For me, it kind of was a gradual decline. I never really felt a dramatic shift in how I felt during the past 20 years. But during the end, in the past few years or so, I could feel my energy level dropping, and that coincided with my labs going down as well.
Christine, what did you notice?
I think the biggest thing that I noticed was the energy level and the ability to just keep up with our very active lifestyle. He tried very hard to hide it. I don't think he really realized how poorly he felt, but looking back, it's very clear that he wasn't feeling great a lot of the time.
Now, when did you find out that you were either going to need dialysis or need a kidney transplant?
It was in January of 2021. It was only 2 weeks after our son Oliver was born. So it was kind of a very jarring experience, being new parents and dealing with that as well. So it was just very jarring for us.
Christine, anything to add of how that impacted your life?
Yeah, that was very dramatic, as you can imagine. We had just had a baby. We did know that he was going to be needing a transplant. We had already discussed that. So the first shock wave came when I was about 6 months pregnant. His health had declined pretty drastically at that point, and they had talked about transplanting, but that it was a little bit of a longer term picture. So we were going to work through some other treatment plans first, but would start the workup process. And then that way, when we got to needing a transplant, at least his workup was complete, except that that timeline got cut short because his body just did what it decided to do. And we needed a kidney sooner than we had anticipated. So yeah, it was very jarring.
When did you learn about the opportunity to potentially find a living kidney donor, and what did you think of that?
We had an initial appointment with the transplant team and Dr. Burke kind of talked about the living donor program and the benefits to that versus, staying on the deceased donor list, and how the lifespan of a living donor kidney on average was higher than a deceased donor, and it would be able to format more of a match through the living donor program.
How did you feel about having to ask someone for a kidney?
Anyone who knows me knows that I'm not good at being vulnerable. I've been working on that, and this kind of forced me to open up my shell. Now I'm an open book, really. But yeah, at first it was hard to get over the hump of showing people that I was vulnerable. Even some of our close friends didn't know the severity of my disease. They knew I had a kidney disease. It was this generic thing about my life that I've had for 20 years, but they did not know the severity until we ended up reaching out to everyone at the time where we were asking for the transplant.
How did you get started in sharing your story?
We took some time for ourselves, to be fair. We had to get, through that initial shock period, but we're pretty proactive people. So, once we got over the initial shock, we made a letter kind of summarizing our story. And then we had a fact sheet also with that letter. We sent it out to our friends and family. So they were able to review it before we had a kind of a group Zoom meeting to kind of give them the situation, and then kind of hear from them what ideas they had or how they thought they could help and things like that.
And Christine, how did you help as a living kidney donor champion?
So it's a lot to process, and Matt also wasn't feeling well, and for us we had a new baby and work demands and things like that. So I really kind of took the reins so that he could participate as much or as little as he felt able to. And the way I went about it was I wrote the letter for him. I compiled the fact sheet using Christiana Care's website and the Kidney Foundation website. And we did all of the communications together. So anytime that we had a call about it or a Zoom about it, we did it together. But then I was the secretary, so to speak. So whenever we would get someone saying, oh yeah, I'm interested, I want to learn more, I took care of pushing out that information to them. And that helped a lot to take hopefully some of the stress off of him. And so I would certainly encourage folks to divide and conquer in that way.
What were some of the avenues that you took in seeking out a living donor?
We kind of hit multi-prong levels, social media, Facebook, Instagram, and very surprisingly, Nextdoor is very helpful in terms of getting the word out. Additionally, people on our network have networks as well. We're able to speak to Rotary clubs through Zoom at their weekly or monthly meetings to get the word out. So we used our network. It wasn't just us. We reached out to anyone that was willing to help us, and we were able to get the word out pretty quick, and set a wide net of people that were able to hear our story.
When did you find out that there was actually a donor for you, a kidney available for you?
We received a call in mid-August, I believe it was August 17th, saying that there was a match, and we were ready to, what we heard was, are you ready to get a kidney on September 1st? And I said, yes. So that is how we heard. And then the next 2 weeks were a whirlwind, and we were just so excited and happy. And between that date and September 1st, we were able to meet Jackie, and everything was great.
So Jackie, how did you hear about Matt's need for a kidney?
Yeah, I heard way back on, I want to say February 15th, which we are quickly approaching our 1 year anniversary there. Scrolling through Facebook, I happened to stumble across a post that shared Matt's story from one of our mutual friends. So at the time, I'd never met Matt or Christine. It was one of their friends who I happened to know who was sharing their story and the background, and it really spoke to me.
Why did you choose to pursue donation? Has it been anything that you'd thought about in the past?
Yeah, so I think what's surprising, I mean, in retrospect to me, is I had never really considered donating an organ. Again, it was one of those serendipitous things where I read Matt's story, and again, it was very relatable, right? I have a young family as well, and my husband has an autoimmune disease. And at the end of the day, if the situation were reversed, right, I would hope that somebody would consider reaching out or just learning more to take the next step to see if they could help. So I wanted to show that type of reciprocity for somebody else when the situation could be so easily reversed.
How was the living donation evaluation process?
It was long, so longer than I had initially thought. I think going into it, I've learned so much about the living donation process and just researching. I think initially you're so excited to learn about it and see if you can help. And it felt long. I think it amounted to about 6.5 months in total. But the reality of that is it felt long because the team is doing such a thorough job of ensuring not only that you're in tip-top shape and healthy enough to donate a kidney to somebody else, but that's going to help provide the best outcome, right, for your recipient. So it felt long in the time being, but it was all obviously for a very, very good reason. So you really feel well taken care of and that your health is being kind of put at the forefront.
How did you feel when you found out that you were actually a match for Matt?
Yeah, I felt thrilled. And for me, I think it's especially early on is like, oh, you get that first wave of like evaluations and you're like, oh, great, we're compatible. And then it's like, all right, well, now we have like 8 more phases in the process, right? To make sure that, again, you're healthy enough to be able to donate. So I was super excited passing that, what felt like that first stage gate, and just continuing down the process was super exciting.
So you all didn't know one another when you first went through this process. So Matt, when did you have the opportunity to find out who your donor is? And then Jackie, when did you meet Matt and how was your meeting?
Yeah, so when we first got the call, we were not sure if we were ever going to be able to meet our donor. And us being the way we are, that freaked us out, that we were not going to be able to meet Jackie. So a few days later, we got a call asking if we would want to meet Jackie. And we said, obviously, sure, yes, we really want to meet Jackie. So we were able to meet the Thursday before the surgery at the Christiana Care Transplant Center. And it was great. It was us, it was Jackie and her husband, and our mutual friend surprised us and came with Jackie to share in the moment.
Yeah, and I would say for me as the donor, right, that was probably one of the coolest parts of the whole experience, because there's so much anticipation and build up, and like this has been going on for months. So I was thrilled to be able to kind of meet Matt and Christine for the first time, because I felt like I had an unfair lens right into their life, and like going through this roller coaster of evaluation process and waiting. And it was definitely a really special kind of moment to be able to kind of put all the pieces together and be able to finally meet and exchange stories along the way.
Jackie, how do you feel being a living kidney donor as part of your identity?
Yeah, I honestly, I feel honored to be totally transparent with, being fortunate enough to be healthy enough to be able to provide somebody with that gift. It's one of the biggest honors of my life.
Matt and Christine, what have your lives been like since receiving this gift from Jackie?
I can say that my energy level has been up. Christine jokes that I run circles around her now, where before, I would, quietly internally, even though she could notice that I was trying to put on a tough face for my family. But now I don't have to. It's genuine energy, and I'm able to do, everything I could, when I was younger, when the disease hadn't progressed as much as it had. So yeah, I could just say just very energetic and happy.
Jackie, what would you like people to know about the living donation process based on your experience?
Yeah, I want people to know, I think there's this assumption out there, right? You're considering like, hey, I'm gonna give somebody an organ. A lot of people assume that must come with like some lifelong implications, like you're not going to be able to continue your lifestyle post-surgery, or you're going to have to be bound to taking medication or something like that for the rest of your life. And for the vast majority of donors, it's simply not true. I know I was able, personally, to be able to get back into my regular exercise routine within 8 weeks of surgery. And regularly now, I forget that I am down a kidney. I forget that I had surgery fairly recently because the impact for me has been so minimal. And, living donation is an amazing kind of tool. I think that's available for people out there to learn more about. And really just, it's the return on investment is beyond measure, is the best way to put it.
Christine, you've mentioned to me that the surgery for your family was just a very small part of this journey. Can you tell me a little bit more about the other things that people should be considering and thinking about with transplantation?
Yeah, so calling it a journey is the most accurate description, because you will go through a whole gamut of emotions and experiences, from the first phone call or meeting, finding out that you need to be transplanting your loved one, all the way until you're taking them home. And then now on the back end of it, it's life-changing. And I think that it's actually been a very beautiful experience for us, because it has shown us such a different side of our community. It's very easy, particularly in the world of COVID and the political stressors we've all undergone the last few years, to get torn into the negative. But the outpouring of love and support has been unbelievable. So to open yourself up to it, be genuine, be transparent, tell people you need help. And then just the logistics of keep the household healthy, stay as active as you can, stay on top of your lab work, stay on top of the doctor's appointments, any medications you're already on, because when that call comes that the transplant is coming, you want the recipient to be in their best shape possible. So keeping them in their best shape, taking care of yourself, which is pretty rich coming from me. It's not really my forte, but it's something I'm learning to do, and figuring out what you can delegate out. When people ask how they can help, give them a task. They genuinely want to help. So find someone to help cut the lawn, find someone to run and get the groceries. Ask for as much help as you possibly can, because it takes a village to bring home a kidney. And it's been the best thing that we've ever gone through, aside from the birth of our child. So,
Matt, do you have any final thoughts on how living donation and this gift has impacted your life?
It's impacted every facet of my life. Like I said, I'm able to play with my son more without burning all of my energy. I'm able to focus better at work. I'm able to exercise more and get in better shape for my family. Every aspect of my life has changed with this kidney.
Okay. Yeah, I would say on the whole, from a living donation standpoint, one of the things that I learned is that there is a very small but mighty network out there of living kidney donors that have been a tremendous help for me as I went through kind of the evaluation process, and just helping to get insight from other people that have gone through it before. And although people might be geographically dispersed, they are some of the most welcoming, thoughtful, kind of supportive people out there. And having that kind of baked in community out there on social media sites generally has been an immense help in going through kind of down this path that not that many, relatively speaking, people have gone down before. So I would definitely encourage potential living donors out there, just generally, if people are interested, to reach out on the social media networks, because everybody out there in the living donor community is amazing, and they're all looking to help support and lift one another up. And hearing their stories has been a huge inspiration for myself and others in going through this journey.
For recipients or people on the transplant list, I encourage you immensely to look into the living donation program. Some tips once you're in the, you decide that you want to take the avenue of living donation is allow yourself to be vulnerable, open up to everyone. If they want to hear, people want to hear your story, they want to help. I would also say that be very proactive in getting your story out. Please know that there are good people out there like Jackie and everyone else that has donated. They're kind, and they want to do good in this world. So just know that there's someone out there for you. Everyone has a spare kidney. You just need to find the one for you, like we did with Jackie.
I would say that the thing I want everyone to remember is that you're not a mind reader. So don't assume you know who's going to be able to help you and who isn't, because we were amazed at who stepped up to the plate. The usual suspects were there in force, but there were some people that really took our breath away with their generosity of spirit and the support they lent us. And I would also say to remember that there is a whole troop of kidney families tucked into every nook and cranny of your community, and you don't even realize it because none of us talk about it. It's not some of the big hitter diseases where you're fighting for your life so obviously. And so I think we tend to suck it up and not talk about it. But now is the time, rip off the Band-Aid, and you'll be shocked at who comes forward and says, I'm in the same boat, or my uncle or my aunt, my cousin. Almost every family has been touched by kidney disease, and we need to start banding together so that folks aren't suffering in silence, because there's no need. We all have a spare. Let's start sharing them.
On behalf of the National Kidney Foundation serving Maryland and Delaware, thank you to our presenters. Fueled by passion and urgency, the National Kidney Foundation is a lifeline for all people affected by kidney disease. As pioneers of scientific research and innovation, NKF focuses on the whole patient through the lens of kidney health. Relentless in our work, we enhance lives through action, education, and accelerating change. Within our market, we have 3 of the best transplant centers across the country. Christiana Care Kidney Transplant Program, the University of Maryland Transplant Center, Johns Hopkins Comprehensive Transplant Center. Additionally, we have 2 great organ procurement organizations within our market: the Living Legacy Foundation of Maryland, the Gift of Life Donor Program. NKF's research grant program has invested over $100 million in support of over 1,000 talented researchers investigating the causes and treatments of kidney disease. Locally, we are proud that NKF serving Maryland and Delaware has invested over $3.6 million in support for over 350 researchers. The NKF Patient Network is the first nationwide kidney disease patient registry developed with the overall goal of improving the lives of people with kidney disease through research, clinical care, drug development, and supportive health policy decisions. We believe the best way to achieve this is by partnering with kidney patients like you.
Welcome to the NKF Patient Network, a new patient portal by the National Kidney Foundation, which has been created specifically to help people with kidney disease keep up with the latest research findings and help find out if a cutting-edge research trial is right for you. This powerful research tool is helping to transform kidney care and research together. You may have recently been told by your doctor that you have kidney disease, but please do not worry, you're not alone. In fact, more than 1 in 7 Americans have kidney disease, nearly 1 in 3 are at risk for developing it, and over 700,000 people have disease that is severe enough to affect the ability of the kidneys to work well. At the National Kidney Foundation, we're a group of health and wellness experts who are here to help. Working with our patient advocates, we've developed this new portal with you in mind. We would like to walk you through the ABCs of this site. A is for actionable, personalized information. Many of you have told us that you're interested in learning more about the cause of kidney disease and what you can do to improve your kidney function or quality of life. Because of this, we have actionable and personalized information that can help you, no matter how advanced your disease is, whether you've recently been diagnosed with early-stage kidney disease, or on dialysis, or have received a kidney transplant. B is for the concept of bringing to light. This is another very important thing that our portal does. Because a critical part of bringing something to light is making sure that it is proven by strong research, we connect you to research that is being conducted by prominent doctors around the country. Medical research is so important because it's the way that doctors around the world know which medicines to use for kidney disease, how to treat people at different stages of kidney disease, and which lifestyle changes to recommend. With our portal, you not only learn about the latest scientific discoveries that might help you manage your kidney disease, but get a chance to participate in research studies that might directly help you or may benefit other patients. Think of us as your one-stop shop for getting involved in and learning from cutting-edge kidney disease research. C is for current. And when I say current, I'm referring to real-time data. One thing that really helps doctors is understanding how thousands of patients with kidney disease are doing in the real world in real time. By contributing to this platform, you and other patients with kidney disease can help doctors around the country and the world get better information that can help them understand what is happening on the ground in real time. So, for instance, if we need to know how people with kidney disease are doing in the pandemic, and 10,000 patients like you respond to our survey, doctors will quickly understand what is happening in the real world and develop quick solutions to improve care. We really hope that you become part of our community, as we want the best for you as someone living with kidney disease. Together, we can transform kidney care, research, and ultimately find a cure for kidney disease.
Whether you need a kidney or are considering a donation, let us help you start the conversation. The National Kidney Foundation offers free resources to patients and families looking for a living donor through the Big Ask, the Big Give program. The Big Ask, the Big Give program is designed to increase kidney transplantation and living donation through in-person or webinar training, as well as direct patient and care partner support. The Big Ask, the Big Give is designed to educate patients about living donation and kidney transplant. It also teaches patients and families how to share their needs and to make the big ask of their family, friends, loved ones in general, or the community to consider making the big give of a life-saving organ. Our patient information helpline, NKF Cares, offers support for people affected by kidney disease, organ donation, or transplantation. It's designed just for patients, family members, and care partners. Speak with a trained specialist who will answer your questions and listen to your concerns. Have questions about kidney disease? We can help. Call us toll-free at 855-653-2273 or email us at nkfcares@kidney.org to get your questions answered. Kidney disease is overwhelming. You may feel lost, alone, or unsure of what to do next. But there is someone who can be by your side throughout your kidney health journey. NKF Peers is a free program for people with late-stage kidney disease, including people on dialysis or those with a kidney transplant, living donors, and people considering kidney donation. Those who join receive one-on-one support from others living with kidney disease, trained to guide and support you. Talk to someone who's been there. Call us at 855-653-7337 or email nkfpeers@kidney.org. Advocacy plays an integral role in our mission. You can make a significant difference in the lives of kidney patients by representing the National Kidney Foundation. You can become an NKF advocate. An NKF advocate is someone who has been affected by kidney disease, donation, or transplant, and who wants to empower and educate others. These include people with kidney disease, dialysis patients, transplant recipients, living donors, donor family members, caregivers, friends, and family members. The National Kidney Foundation is the largest, most comprehensive, and long-standing patient-centric organization dedicated to the awareness, prevention, and treatment of kidney disease in the United States. Together, we can enhance the lives of kidney patients by making our voices heard in support of the issues affecting funding, treatment, research, and more. There are many ways to become engaged. Join the effort today. To learn more or to become an NKF advocate, visit www.kidney.org today. Join us as we highlight the latest in kidney research, dispel myths, bring you up-to-date news in kidney care, and answer questions from patients to help them live well with kidney disease or transplant. You can subscribe to our kidney podcast via Apple Podcast or Spotify. Visit www.kidney.org to check out the various topics in our library. The National Kidney Foundation's Kidney Cars program has been the most trusted car donation program for more than 30 years. While most donations are cars, trucks, or vans, the Kidney Car program also accepts boats, motorcycles, motocross bikes, power sports equipment, personal watercraft, and even farm equipment. Your vehicle donation ensures that the National Kidney Foundation can continue to provide the highest level of support and guidance for kidney patients and their families during challenging times. The National Kidney Foundation, serving Maryland and Delaware, hosts our premier foodie event, Sante, annually. Guests savor Maryland's best dishes and cocktails, all while fighting kidney disease. This is a business casual evening, including tastings from a variety of restaurants, paired with enticing beverages. Guests enjoy a silent auction, awards competition, photo booth, raffles, and more. Proceeds from the event support emergency funding for kidney patients and medical research at Johns Hopkins and the University of Maryland. Visit us at www.kidneymd.org for more information. Take your best shot. The National Kidney Foundation's Konica Minolta's Golf Classic is a national series of amateur golf tournaments benefiting the National Kidney Foundation. The road to Pebble Beach starts at a tournament near you. The top teams finishing in both the gross and handicap index divisions from every National Kidney Foundation Golf Classic across the country are invited to compete in the national finals held at the famed Pebble Beach resorts. If the U.S. Open is not in your future, this tournament may be your only chance to compete for a national title, all while supporting a charity. Take a swing with us and register your team today at www.kidney.org. Kidney walks are a vital source of support as we provide real-time assistance for those in need. More than 82 cents of every dollar donated goes to research, patient services, professional education, public health education, and community services. Visit www.kidneywalk.org and locate a Kidney Walk site near you to register your team today. Social media is a vehicle that allows the National Kidney Foundation to communicate with our community in a quick and informative manner. Follow us on Facebook, Instagram, and Twitter locally. On behalf of the National Kidney Foundation serving Maryland and Delaware, our Medical Advisory Board, and our Board of Directors, we give many thanks to our sponsors who made this program possible: the University of Maryland Medical Center and Horizon Therapeutics.